Imagine, just for a moment, that you are waking up right after a major surgery,
Oh, yeah, that is rough.
right? You open your eyes and the sensory input is just entirely disorienting. Like the fluorescent lights above you are glaring. Your body feels impossibly heavy, deeply sore, and your mind is clouded with this lingering heavy grogginess from the anesthesia.
Exactly. It's awful.
And all around you is just a symphony of clinical chaos. I mean, monitors are alarming, nurses are rushing past, pneumatic pumps are humming, and beneath it all, you just feel this overwhelming sense of, well, physical vulnerability.
Yeah, it is arguably one of the most jarring transitions the human brain can undergo. I mean, you are being pulled from a state of medically induced chemical unconsciousness straight into a highly active, heavily technical recovery environment.
Yeah.
Your body is essentially in a state of controlled trauma.
And that specific environment, the perioperative journey, spanning from the moment you anxiously sit down in the waiting room to the hours you spend in the post-anesthesia care unit or the PACU, that is our focus for this deep dive today.
That's a great topic.
Yeah, and our source material today is this fascinating collection of clinical abstracts from an ACE-PAN national conference. So ACE-PAN being the American Society of Perianesthesia Nurses.
Right, meaning this data is coming directly from the professionals who run these units on the ground every single day.
Exactly. And we're also pulling some insights from a corresponding nursing research publication. So it's a solid stack of data.
It really is. And the overarching narrative in these sources, it highlights a side of healthcare that rarely makes the front page of medical journals. We are heavily conditioned to marvel at the technological leaps in medicine.
Oh, for sure, like robotic-assisted surgery or
Yeah,
artificial intelligence.
right. Advanced microscopic imaging, all of that.
Yeah, you picture cutting-edge medicine, and the mind immediately goes to, like, lasers, glowing screens, and multi-million-dollar surgical suites.
Yeah, the flashy stuff.
But our mission today is to explore a radically different theme that's emerging in modern perioperative care. We are looking at how some of the most effective, like mathematically verifiable solutions in these high-stakes environments are, well, surprisingly simple.
Extremely simple.
Yeah, they are profoundly low-tech, and they center entirely on basic human sensory management. Sometimes it's about communication or cotton or a good playlist.
And that contrast is what makes this data so compelling. As the technology in the operating room reaches unprecedented levels of sophistication, clinical outcomes are increasingly hinging on whether we are managing the patient's fundamental sensory level environment.
Just to allow that highly technical surgery to heal properly.
Exactly.
So let's start at the very beginning of the timeline. Because before a patient ever sees the inside of an operating room, before a single incision is even made, a massive psychological toll begins.
Oh, the waiting room.
Yes, it starts in the most mundane, universally dreaded space possible, right? The preoperative waiting room.
Which is a space historically defined by a severe lack of information. I mean, the anticipation of surgery is a unique psychological burden for you and your family.
Yeah, waiting is the hardest part.
And when delays happen, which, let's be honest, is an inherent reality of hospital operations, whether it's due to a previous trauma case running long or, a sterilization backup.
Right, stuff just happens.
Exactly. And the patient and their family are often left in a complete informational void.
And the first initiative we were looking at aimed to solve that specific void. A hospital recognized that these preoperative room delays, combined with a total lack of communication, were causing cascading issues.
Big issues.
So their intervention was remarkably straightforward. I mean, they didn't build a complex digital tracking system or like a new app for families to download.
Thank goodness nobody wants another app.
Right. Instead, they created a standardized, full-time patient liaison position. They literally just placed a dedicated human being in all 5 of the preoperative waiting areas.
And they started their shift bright and early at 06 under day, 6 in the morning.
Yeah, and their sole operational duty was to continually update patients and families on the schedule.
Just talking to people. And the data they collected from fiscal years 2015 and 2016 following this implementation, it showed a 99 to 100% improvement in family notifications.
Which is wild.
It is. Furthermore, formal complaints regarding unattended lobbies or a lack of morning updates dropped to absolute 0.
Okay, I have to pause on that metric, though, because, well, a 0% complaint rate sounds incredible on a hospital management slide, but it begs a critical question for me.
Sure. What's that?
Did patients and families actually experience a reduction in psychological anxiety? Or did they just stop submitting formal complaints because they felt, socially obligated to be polite, to the nice person sitting in the lobby with them.
I see what you mean.
Like, wait, so they just put a dedicated person in the lobby to talk to people? Isn't that just basic customer service?
Yeah.
How does this qualify as a measurable clinical improvement?
That is a highly valid skepticism. It really is.
Yeah.
Especially if you view the waiting room as totally separate from the surgical suite.
Right, like it's just a lobby.
But the medical literature connecting psychological stress to physiological outcomes, well, it bridges that gap entirely. When you leave a patient in an informational void before a major procedure, their anxiety compounds.
Makes sense. I'd be terrified.
And that anxiety isn't just a feeling, It is a measurable physiological cascade. The sympathetic nervous system kicks into overdrive. The adrenal glands dump cortisol and catecholamines directly into the bloodstream.
Which means their heart rate elevates, their blood pressure spikes, and they are essentially entering a state of fight or flight, right?
Exactly.
Right, when their body needs to be prepping for systemic trauma and recovery.
Yes, and that biological state actively works against the anesthesiologist. Bringing a patient into the OR with highly elevated baseline stress hormones, it impacts how their body metabolizes anesthetic agents.
Wait, really? The stress changes the anesthesia.
Oh, absolutely. It causes peripheral vasoconstriction, which impacts tissue perfusion and even just getting intravenous access. It fundamentally alters the trajectory of how they will emerge from that anesthesia hours later.
Wow.
So by having a liaison constantly neutralizing that informational void at 6:00 a.m., the hospital is actively lowering the patient's circulating cortisol levels. It is literally preoperative, non-pharmacological stabilization.
See, that reframes the entire concept of the waiting room for me. It's not a holding pen. It's actually the first phase of treatment.
It really is.
You are optimizing the biological environment for the surgical trauma by actively managing the psychological environment beforehand.
We often separate the mind and the body in surgical contexts, but, the central nervous system doesn't make that distinction at all.
That is fascinating. Okay, so we've established how crucial it is to optimize the psychological baseline before the operation. But eventually, the surgery happens, the anesthesia begins to wear off, and the acute physiological reality of the procedure sets in.
The hardest part.
Yeah, which brings us to the visceral physical pain of waking up in the PACU.
And the statistics from our sources on this phase are pretty sobering. Even with modern analgesics, approximately 80% of surgical patients will experience moderate to severe pain in the immediate postoperative period.
80%, that is a staggering majority.
It's a lot.
And managing that isn't just about making someone feel nice, right?
No.
Uncontrolled pain initiates another severe stress response that impedes wound healing, suppresses the immune system, and ultimately prolongs hospitalization.
Which is exactly why this next study is so important.
Right, this brings us to the primary investigation in our stack, led by Fiona S. Smith at Houston Methodist Sugar Land Hospital in Texas. And their study focused specifically on ambulatory orthopedic surgical patients.
Yes.
But why single out orthopedics, though?
Focusing on orthopedics is a very deliberate methodological choice. If a clinical team wants to rigorously test a novel pain reduction intervention, they really need to test it against one of the highest thresholds of pain.
I get it. Make it hard for the intervention to work.
Exactly. And orthopedic surgeries involve cutting through highly innervated periosteum, manipulating bone marrow, and causing extensive deep tissue trauma.
Sounds agonizing.
It is. It represents a massive release of inflammatory prostaglandins. So it is widely considered the ultimate testing ground for analgesic theories.
Wow, okay. So if you can find a way to non-chemically blunt the pain of someone having their bones manipulated, you have a highly significant finding.
Precisely. And the intervention the Houston Methodist team implemented was music therapy.
Just music.
Just music. But they approached it with strict clinical rigor. They gathered 3 months of baseline data on a control group without music, meticulously tracking every single milligram of intravenous narcotic medication used and calculating the exact length of stay in the PACU.
And then following that baseline, they introduced music therapy for the subsequent 3 months to the exact same demographic of eligible orthopedic patients.
Right. They gave them music to listen to while they recovered.
The neurology behind why this works is fascinating to me. I think of it like noise-canceling headphones, but for your brain's pain receptors.
That is a great analogy.
Because the gate control theory of pain suggests that the brain only has so much processing bandwidth,
Right.
So if a patient is lying in a sterile room listening to the alarming beeps of a monitor, 100% of their sensory bandwidth is focused on the nociceptive signals, like the throbbing pain coming from their surgical site.
Exactly. But by introducing complex, structured auditory stimuli like music, you force the auditory cortex to consume a large portion of that processing power.
You are flooding the central nervous system with non-painful sensory data.
Yes. Because pain is ultimately a perception generated by the brain, occupying that neurological bandwidth literally turns down the volume on how the brain interprets those nociceptive signals from the leg or the arm.
But looking at the pharmacology data from the results, though, the nuance here is really critical.
Mm.
I noticed right away that the patient's overall length of stay in the PACU did not actually change.
No, it didn't.
And more importantly, their average use of fentanyl did not show a statistically significant decrease either. So if you just skim the abstract, you might assume, well, the music didn't actually do anything.
And that's where you have to look closely at the specific roles of the different narcotics to understand the victory here.
Okay, break that down for us.
So fentanyl is a highly potent synthetic opioid. It acts as a primary mu-opioid receptor agonist. In an orthopedic context, it is the foundational bedrock of early recovery anesthesia.
Right, because you can't just meditate your way out of a freshly sawed femur,
Exactly. You really can't.
The baseline trauma requires heavy chemical intervention.
Right. The baseline fentanyl requirement is largely immovable, but the massive breakthrough in the Houston Methodist data was found in a completely different column of the medication chart.
Which was the usage of Meperidine,
Yes.
also known as Demerol, right?
That's the one.
And the usage of Meperidine experienced a highly significant measurable drop in the music therapy group.
And meperidine is another potent narcotic, but it has a very different application profile in the PCU. It is frequently utilized to manage postoperative shivering, known as rigors, and to attack breakthrough pain that the baseline fentanyl just isn't fully covering.
Okay, so it's the backup med.
Yes, and the issue with meperidine is that it metabolizes into normeperidine, which is highly neurotoxic and has a very harsh side effect profile, especially on the renal system.
Wow. So the data is telling us that the music therapy successfully replaced the body's demand for that secondary, highly toxic breakthrough narcotic.
Exactly. The music didn't magically erase the bone trauma, obviously, but it absorbed enough of the sensory bandwidth that the patient's central nervous system simply didn't require that extra damaging layer of chemical intervention.
That is incredible. You are literally sparing the patient's liver and kidneys from processing a heavy, potentially neurotoxic synthetic opioid simply by manipulating their auditory environment.
Yeah, just by putting on a playlist.
Yeah.
And the subjective data aligned perfectly with the pharmacological data, too.
Oh, right, the Press Ganey scores.
Exactly. Alongside the drop in meperidine, the patient's Press Ganey scores showed significant improvement. And we know Press Ganey surveys are the absolute gold standard for hospital reimbursement and measuring patient satisfaction regarding pain management.
So the patients actively reported feeling more comfortable, and they felt their pain was managed better, all while consuming fewer dangerous narcotics.
It's a win-win. And this synergy of subjective comfort and objective pharmacological reduction is exactly why the Agency for Healthcare Research and Quality officially recommends music therapy now.
That makes total sense.
It is an entirely non-pharmacological tool with a zero-risk profile. There are no contraindications, it doesn't interact with anesthesia, yet it alters neurobiology enough to physically change medication charts.
I love that. So we've just seen how actively introducing a positive sensory input like music can heal and protect the body from excess chemicals.
Oh.
But there's a flip side to sensory input into the PCU.
There is.
What happens when the physical inputs, specifically the automated machines designed to keep you alive, start causing mechanical harm?
Yeah, this represents one of the more insidious dangers in acute care settings.
It's scary to think about.
It is. The postoperative environment relies heavily on continuous physiological monitoring, but we often completely overlook the physical interface between the patient and the machine itself.
Which brings us to the final study from Mercy Medical Center in Baltimore.
Right.
In 2013, over a relatively short 5-month window, their PACU identified a highly concerning trend. 9 separate patients suffered from medical device-related pressure ulcers, or MDRPU.
Which is very high.
Yeah, and we all know how fast a pressure ulcer can develop on a sedentary patient like, typically on the heels or the tailbone from just lying in a bed.
Yeah.
But what caught me completely off guard was the mechanism of injury here. It wasn't the bed.
No, it
It
wasn't.
was the blood pressure cuff.
The very device strapped to the patient's arm to monitor hemodynamic stability was causing severe localized tissue necrosis.
That is shocking.
Right.
I mean, a blood pressure cuff causing an ulcer sounds almost contradictory until you look at the biomechanics of a recovery room.
Uh-huh.
A BP cuff in a PACU isn't like the one at your annual checkup, right?
Not at all. It is programmed to pneumatically inflate and squeeze the arm every few minutes continuously for hours on end.
Wow.
And you have to factor in the state of the patient's epidermis. Post-surgical patients often have compromised peripheral circulation, their skin might be incredibly fragile, and crucially, they are immobilized by anesthesia.
Right, because a conscious person will make like micro movements to relieve discomfort when a nylon cuff squeezes their arm. A sedated patient literally cannot.
Exactly. So you have rigid nylon rubbing against the same exact patch of fragile skin, inflating to a high pressure, collapsing the superficial capillary beds to cut off blood flow momentarily, and then deflating.
Over and over.
Doing that constantly creates immense cyclical shear stress.
Ouch.
The repetitive friction and concentrated mechanical pressure effectively starve the underlying soft tissue of oxygen, which leads to rapid cell death.
And the challenge for the clinical team is that continuous blood pressure monitoring is totally non-negotiable. You cannot simply turn the machine off to save the skin because you need those vitals to ensure the patient isn't hemorrhaging.
You're stuck between a rock and a hard place.
But the response from Mercy Medical Center is a masterclass in clinical problem solving. I mean, they didn't just isolate this to a single department. They formed an interdisciplinary perioperative skin committee involving certified wound and ostomy nurses, staff nurses, informatics specialists, and physicians.
They brought everyone to the table.
Yeah, and they executed a massive literature review to find evidence-based practices for device interfaces.
Because when dealing with biomechanical shear stress, the fundamental goal is to alter the coefficient of friction between the device and the epidermis without interfering with the pneumatic compression required for the medical reading.
And their solution is honestly my favorite part of this entire deep dive.
It's so good.
They didn't petition the hospital board for a $1 million next-generation AI-calibrated blood pressure cuff with softer nylon.
Nope.
They just went into the medical supply closet and grabbed a stockinette.
A simple tubular sleeve made of cotton and polyester.
That's it. They implemented a protocol where this fabric sleeve was placed over the patient's arm, acting as a physical barrier between the bare skin and the nylon cuff.
And it cost pennies.
Literally pennies. But by putting a basic piece of cotton between the patient and the machine, the clinical impact was monumental.
By analyzing the data from the entire year following the implementation of this specific protocol, the incidence rate plummeted.
From 9 severe ulcers in just 5 months, the hospital recorded exactly 2 incidents for the entire subsequent year.
And the most telling detail of the entire study, which I love, when the committee investigated those 2 specific cases, they discovered the stockinette protocol had not actually been followed.
So it demonstrates a functional 100% efficacy rate when the intervention is applied.
It's amazing. The cotton and polyester fabric completely absorbed the frictional shear stress and diffused the mechanical pressure against the stratum corneum, preserving the capillary beds.
All while still allowing the cuff to accurately read the systolic and diastolic pressures.
It is brilliantly simple.
It really is. Stepping back and looking at the entire perioperative journey we've mapped out today, a very clear narrative emerges. We started at 6 a.m. in the waiting room, where simply providing a human liaison to communicate information halted a physiological anxiety cascade and optimized the body for anesthesia.
Right. And then we transition into the acute recovery phase, where intentionally managing the auditory environment with a playlist of music successfully hijacked the brain's processing bandwidth, reducing the physical requirement for a highly toxic secondary narcotic.
And finally, we looked at the physical environment, where a few cents worth of cotton and polyester completely neutralized a dangerous mechanical shear stress caused by a life-saving machine.
Whether it is communication, an auditory melody, or a simple fabric barrier, the overarching theme is totally undeniable.
Yeah, the true optimization of human healing in a modern clinical setting is inextricably tied to low-tech, compassionate, sensory-level interventions.
And the actionable takeaway here for you as the listener is highly practical. The medical system can feel incredibly overwhelming, almost as if you are entirely at the mercy of the pharmacology and the machinery.
Oh, absolutely.
But understanding this data empowers you. When you or a family member are navigating a surgical environment, do not solely focus on the technology. Pay clinical-level attention to the environment.
Advocate for the auditory landscape. You
Yeah.
know? Request the music. Demand the communication. Ensure the physical interfaces are protected.
Because these elements are not just superficial comforts. They are scientifically validated, mathematically proven variables that alter neurobiology and change medical outcomes.
Exactly. And before we wrap up, I really want to emphasize how much adding music to your life is better for your health, especially when people are in high-stress environments like the PACU.
Oh, absolutely. It's a game changer.
It really is. And if you want to dive deeper into studies like the ones we talked about today, promote Orium's Fit Research Digest is honestly the best place to find the latest and most important health studies.
It definitely is. It's an incredible resource.
Yeah, it's where we simplify, explain, and also do podcasts just like this one. Plus, we always give links to the original study so you can check the data for yourself. So make sure to follow us on Facebook to stay updated.
Highly recommend checking that out.
So, to close out our deep dive today, I want to leave you with a final thought to mull over. We've just examined rigorous clinical data, proving that something as intangible as a simple melody can genuinely reduce a human being's physical requirement for a strong synthetic narcotic immediately following major bone trauma.
It's wild to think about.
It is. So if managing sensory bandwidth is that powerful of a medicine in a high-stakes surgical recovery room, what other everyday sensory inputs might we be completely ignoring?
That is a great question.
Think about the specific lighting in your office, the ambient noise in your bedroom, or even the textures of the clothes you wear every single day.
Small things add up.
Right. How much of our own baseline stress and our own daily physical aches could we heal just by finally paying attention to the simple, low-tech environments we build for ourselves? Think about it.